Okay, welcome folks to the Freedom Hub's final cash patient webinar of the year. We're very excited to have Patsy Writesman coach us on upgrading from being a passive patient to a vigorous shopper of health services. It's a big time for healthcare as folks realize that the same old isn't going to work anymore, and they have to help us fix the system by becoming educated. And if you're looking at the screen, you'll see a couple links. That first Brighteon link is where you can see all of our videos, and I'll take a quick look here. We have migrated from Vimeo to Brighteon to house our videos, so you only see a little over half a dozen of our recent weekly webinars. Please click on them and give us some likes and views. And the reason that we're housing our videos here and not at Vimeo or YouTube is we don't like censors. And then, let's see here, the other link I want to show is the main archive. Is a bit.ly, bit.ly / all caps cash medical channel with 2 N's, 1 L. And there you can see the other videos going back about a year now with this nightly, weekly event. And this is sponsored by yourfreedomhub.com, which seeks to unite activists and entrepreneurs for a better world. Tonight, we have Patsy Writesman, who is a Platinum Ambassador for Universal Health Advisors. I met her a year ago or so through LinkedIn. She speaks all over the country to groups on how to become a smart healthcare consumer. She got her experience as a Medicaid contractor at Ross Perot's company, EDS, where ironically I actually interviewed back in the 90s. And these are big contracts, it's a big company, and if there's anywhere you can learn about the pros and cons of healthcare, is trying to improve the 50 states' efforts to give healthcare to the poor and elderly. That is a complicated animal, and I look forward to hearing from Patsy on how that works. And so with that, I am going to show her LinkedIn for those that want to see more about her profile at LinkedIn. Just search Patsy Writesman at that page.
Okay. It has been my passion for the last few years. I did work for Ross Perot's company for 20-something years, running Medicaid programs across the nation, and then went out on my own. And the cost of healthcare in the U.S., as we all know, it's going to break us. So I have 3 lines of business. One is doing presentations to organizations, associations, legislative groups. A second line of business is I do a monthly electronic subscription on what's happening in healthcare, CEOs, legislators, congresspeople, some independent business owners. And then a third component of my business happened by accident, and that's every presentation I did, I would have people contact me afterwards and say, I have some huge hospital bills, could you look at those? And I hear that I have yet to see, and looking at several hundred bills, I have yet to see a hospital bill that was 100% accurate. So I will start with there. The main statements I get after a presentation, and I get these after every presentation, is I had no idea that could happen, and I wish I'd known that sooner. So those are the 2 main statements, and I want to impart some of that tonight. My website is managehealthcarecost.com. My LinkedIn profile, I speak for Universal Health Advisors and also speak with a speakers bureau called Speakers You Need, so I just added that information in there. In the United States now, medical bankruptcy is now the primary reason for bankruptcy, and that includes even people with insurance. The latest statistic was 18 cents of every dollar goes to healthcare in the U.S. now. I think the most important thing for us to know is it is imperative to become more engaged as healthcare consumers and as business owners with healthcare. And what I'm going to do as I go through this is I'm going to give you some examples. I think that's the easiest way to wake us up, although I think those on this call and on this presentation are already in that vein. But what we don't know financially and medically can hurt us. My mom was in the hospital a month ago, and it is now a federal law, as we know, that if you are in observation status, that it is a law that the patient be told and made aware that they are in observation status. What that means is you may be in a hospital room, you think you are an inpatient because you are not in a hospital room and you're getting services, but in fact, you can be in observation status. And I'll point out a couple of things on that. One, hospitals are now getting dinged financially if they have readmits, particularly for the older patients. So if they can keep a person in observation status and not as an inpatient, if that person comes back, they're not seen as a readmit, and the hospital does not get penalized the same way financially. My mom was in the hospital. And after 2 days, and I did not leave her sight. I was with her 24 hours a day. They had never told her she was in observation status. And I said to the physician, could you just check the records and see if she is in observation status or is she an inpatient? He checked and she was in observation status. What that meant was if she was going to go to rehab afterwards, if she had not been an inpatient for 3 nights consecutively, they would not have paid for rehab. So, and I said, why is she in observation status and what can we do to ensure that this goes to an inpatient status? And what he told me was surprising. He said, Patsy, the physicians don't even make that decision anymore at this hospital. And it is a large hospital group in the Nashville area. It's the St. Thomas system. And he said there is a committee now, and they determine based upon the records they're reviewing whether or not it's observation or inpatient. And I said, what can we do? So he changed some things which he felt like would make her be an inpatient, and that did happen. But if I had not asked that question, even though there is a law that she be told, we would not have known that. And there could have been some very large charges afterwards. So one of the biggest things from this presentation is ask questions, ask questions, ask questions, and document everything, because that's where we fight the system. The next point, just not being engaged, not being educated, but we have not had to be engaged or educated in the past because things seem to flow. We didn't get those large charges, but those things have changed. And my initial interest, I've lost 2 brothers to heart disease. My initial interest on what was happening with cost was on one of my brother's bills. I was looking at a detailed bill and I saw a $127 charge. I drilled down and found out that that $127 charge was, in fact, for a 15-page Xerox brochure. They were out of the regular brochures, and they had made copies of 15 pages, and he had been charged $127. And I think that was my first aha moment to say, things are not okay always, and I need to start checking things. And so that's kind of what got me in this direction versus where I was going corporately. But I do want to, and I'll give you some examples as we go through, just to learn about the importance of documenting, of asking questions, of at times recording calls, recording phone conversations. Even when you call, let's say that you're calling about a bill, and at the beginning of that conversation, there is a recording that says this call is being recorded. And I'll tell you in a few minutes how that helped us win a case of several $1,000s, because I asked them to go back and get the recording to prove where they had told my client something, and it helped us win the case. Down at the bottom there, the client moved in November. She was on Obamacare. She had fully met all of her deductibles, et cetera. And she moved about 10 miles in November to another county. She called and they updated her records, and then she had a bad automobile accident. After the automobile accident, the bills started coming in, and they had started her over because they had put her in another plan because she had moved to another county. And when we started asking questions, she could have gone to her same providers because it was just about 10 miles. And that was where I asked. They said, well, we told you. And I said, then I need you to provide that recording that you say you have recordings of for that date to prove that you told her that things would start over. And that helped us win the case, and it saved her several $1,000s. As I go through this, I want to say a couple of things. One, I have tremendous respect for the medical community and the physician community. I have great concerns about what's going on administratively and how it is costing us literally millions and millions and millions, and it's breaking consumers. This is just one chart. There are many out there. This is one chart of what's happening. You will see the physician growth here. This is the administrative growth. So we are paying for administration is what's happening, I think, so much in our healthcare system. Actually, the numbers are this says 2,300% increase. The last stat I saw was 3,500% increase. So what's happening is we are paying for the administrative burden. Just some questions that I would have for you to wake us up. Did you know that if a hospital is in your insurance network, some of the service or providers will probably not be in your network, and the patient will most likely be responsible for those? Just on Capitol Hill in the last month, there's been a lot of debate going on. Senator Alexander's Committee on Health, they've been negotiating some on what to do about those balance bills. But a couple of examples there. My second brother, who passed away a couple of years ago, it was terrible because he had a heart attack and was unconscious. He was taken to the hospital, and I couldn't believe one of my first thoughts, in addition to, I hope my brother's going to make it, my second thought was, I hope that they are taking him to a hospital in network. And I thought, aren't we in a sad state where a person even has to think that? But even if you go to a hospital in your network, and you on the call probably know this, there are a number of people who are not in the network. And many times, sometimes the insurance company will pick up a part of that, but many times the patient is on the hook for those extra charges. So to be aware of that. Did you know that 8 out of 10 hospital bills contain errors? And as I mentioned, I have yet to see a client bill that does not contain errors. I have this on a bullet point later on, but I will mention that always, always, always ask for a detailed bill. You might not know this, but some billing departments are given classes on how to keep you from getting your detailed bill. Because that's where you're going to find the errors in the bills. And it is a law. They have 30 days to get it to you. Another client of mine called and asked for her detail bill. And they said, well, you wouldn't understand it. And I was able to give her the verbiage of the law. And she said, you have 30 days to get it to me. And when we looked at the detail bill, there was a total of $10,000 that she did not owe. So it's just so important that you do it. I've already mentioned, did you know you can be in a hospital bed in a room and not considered an inpatient? Did you know that 2 identical procedures can have drastically different prices in the same hospital? One example, this was an article, one example was, and I'm going to move this box so I can see this, was $339, same procedure, same hospital, charge someone else $3,484. So even in the same hospital, there can be drastically different charges. We need to, if it is not a dire emergency, ask questions, find out those things on the front end if we can. And did you know now that some of the largest insurance companies are changing how they will determine whether something is an emergency or not? There are a number of examples recently. I had 2 articles where physicians went to the hospital themselves. Now, they are medically trained. They felt like there was an emergency. One of them thought he was having a heart attack. They went to the hospital. And because the diagnosis, it wasn't based upon the symptoms, but the diagnosis was considered not to have been a heart attack or something emergent. And those two physicians ended up being responsible for the ER bill. That is happening in several states. I think it's United. I have it listed a little bit later on where they are trying it now. So if a medical provider who has been trained and gone to medical school feels like they need to go to the ER, how about those of us who are lay people and feel like we need to go to the ER? But some of the insurance companies now are stating that if the diagnosis is not emergent, then we can be responsible for that bill. Did you know that insurance copays are higher than the cost of the drug about 25% of the time? There's an example, and there's the article mentioned there that you all can look up, where a patient paid a $285 copay for a $40 drug. Later on, they asked if they could get the drug for cash, and it was $40. They couldn't believe the difference. And up until about a year ago, there was a gag order on pharmacists. Unless you asked the question, some of those pharmacists could not let you know that there was a cheaper way to get your prescriptions. I've got some examples later on, because pharmacy is a huge cost for us in healthcare now, but I have some examples later on of questions to ask, of things that you can try and things that you can do. There are ways that you can look up prices. And just in this example below that I have here, within driving difference, the price of one medication was $381 difference, just if you looked and you used a tool to look up the variance in the medication. And that's huge. It's absolutely huge. This was the article that talked about the $285 copay for a $40 drug. And there's just more information about that if you want to go back and look at the slides a little bit later. Healthcare costs are now continuing to increase and outpace inflation. It is the second cost for businesses next to salaries now. Wall Street Journal, Forbes have both had articles recently that in 2019, employer-sponsored health benefits cost about $15,000 per employee. And I think sometimes this is like the stepchild for employers. They have not had to know about health costs in the past, but it is such a significant part of the bottom line. What I hope, in addition to doing things like Charles is doing now, I hope they will realize if they can also educate their employees, it will save them on cost. Plus, it's like giving an employee a raise, because if employees are having to pull out of their pocket a significant amount of money versus doing things like I'm talking about, it's like a raise for employees because they are not having to go bankrupt in some instances. The next bullet, and Charles, you have options here like DPC, cash paying, but helping the employee save helps the company save money as well. Employee education in primary areas, the emergency room, I've already given a couple of examples like that, and where the doctor's diagnosis versus the symptoms. ERs are a huge got you area. You can receive expensive bills when you don't even receive the care. I've got an example a little bit later of $5,700. Let's go to that. In 2016, there was a patient, she went to the ER. She was simply given an ice pack. She received no other treatment. She never received a diagnosis, and she received a bill for $5,700. We can fight those things, hopefully, if we will just learn that we can fight them and how to fight them by getting the detailed bill. And a couple of situations that I've done in the past, I've gotten the insurance commissioner involved in Tennessee. There was one, it was about $15,000 that we did not think should have been paid. My client said, if I owe it, I want to pay it. But if I don't owe it, I don't want to pay it. And it was about $15,000 worth. We continued to contact the hospital. We did not get any, they just wouldn't work with us. So I contacted the commissioner, and it's a different administration now. I hope the next insurance commissioner is as good. But when we got the insurance commissioner involved and copied the person over the hospital, we were able to take care of it. And I hate to say that you have to go to that extreme sometimes, but sometimes you do. I mentioned earlier, always, always, always get the detailed bill. There was an article last year, an example of a woman that had gone into the ER. They put a bracelet on her arm. She never received any care and got a bill for several $1,000s. And that is happening. That is happening. I've already mentioned the out-of-network and balance bills. Another example that I have, and I just want to give you examples for you to realize that it's happening quite frequently and we need to pay attention. Another person had gotten a $629 bill for a Band-Aid. The doctor ran her finger under the tap water, stuck a Band-Aid on it, and she got a bill for $629. So because of what's going on, I mentioned earlier the health insurance tactics with not paying if it wasn't an emergent, but they are constantly doing different things. I do want to make a suggestion. If it is not something like a heart attack or something where you are immediately taken to the hospital and you are using insurance, there is typically a phone number with that insurance company. And on the way to the hospital, I would call them, let them know what was going on, document who you were talking with so that later on, if they come back to say they will not pay it, that they actually on the phone told you to go to the ER, document who you were talking to. And aren't we in a sad state where we are going to get medical attention and we are having to battle these kinds of things? Probably a lot of you know on the phone, though, that there are 85,000 codes now. So sometimes the billing errors that are occurring, they are valid. They are just, with 85,000 codes, you're going to make some honest mistakes sometimes and put in a wrong code. But there are also some things that are being done that I think are unethical. I think there are times when there is upcoding done or double billing. And I'm going to give you a hotel example just to put the logic here. If I go to a hotel and I check in and they say my room for the evening is $185, that's what I'm expecting. But let's say I check out and they say it's going to be $293, and I'm saying, wait a minute, you told me my bill was $185. Well, but the curtains were this amount of money. The mattress was this amount of money. So basically what they're doing is they can sometimes, in essence, be double charging you. And we find things like that when we're looking at our detailed bills. Always ask for cost up front if you can. We know now that there's what's going on is hospitals are going to be putting their prices, quote, on their websites. What we're finding is that those are hidden. And what price is it? Because like the example I showed a little bit earlier, the price can vary. So what price are they actually putting on the website when we can find it? Document thoroughly. This is one of the biggest points I will make in this phone call to anyone getting medical care. Document everything. Document phone calls. Have a medical notebook. Document phone calls that you are making. Document who you're speaking with, the time that you're speaking with them, what the conversation was. I had a client, and because she had such good notes, that's how we battled several $1,000s. You might also record the call. Know what your laws are in the state. Sometimes it's just just one person has to know. But I suggest in these types of recordings, let them know I'm recording this call so that we can make sure that there's an understanding of what I'm being told. I might also suggest that sometimes you call again and talk with a different person and find out if you are getting the same answers or not. Again, I am just overwhelmed that we're having to go through and jump through these hoops to get medical care. And I've already mentioned that about recording the call. And y'all, excuse me, I'm a little bit nervous. I've never done a webinar before. I'm always used to being up in front of a group of people. So thank you for enduring me on this.
Great.
The last bullet on that, if somebody states that it is a law or a policy, have them provide what that law or policy is. And I'm going to use a friend's example on this. I had a friend whose mother was in an assisted living, and she was known to fall. Every time she would fall, and I mean, not hurt anything, but she would just stumble and fall. They would put her in an ambulance and send her to the hospital. And what was happening, because she would get there, there was really nothing wrong with her except she had fallen. And so my friend's family was having to pay all of these ambulance bills. So on one of her falls, Matt went to the assisted living. He lived close by, and he said, she doesn't, first of all, he said, I want her to go to the hospital if she's hurt. Please understand that. But she doesn't appear to be hurt. So why are we sending her to the hospital? And what the assisted living director told him was that it's the law. And he said, well, I am going to sit in your office until you can produce and show me what that law is. And guess what? They could not do it. Sometimes I don't think that is intentional. I think maybe if staff is trained, that they're just taught that, well, that's a law, and so that's all they know. But again, I'm going to go back to question everything. Question everything. Ask whenever you can. Document. I have a recorder on my phone, and I will let people know I am recording this, whatever is said. How much will this procedure or test or surgery or exam cost, and what are the additional costs? If any of you have had medical procedures, you know, you think the procedure is going to cost something, and then you get all of these other bills that start coming in. Doctors you didn't know, labs you didn't. So ask about all the extraneous costs that you might see. It's important to find out where the procedure is going to be done. If the procedure is done with an entity affiliated with the hospital, it might not be on the hospital grounds, but if it is done in an entity affiliated with the hospital, you may be paying several $100s or $1,000 or more dollars more to have the same procedure done because it is done with an entity affiliated with a hospital. So those questions are important. Policies and plans. And what I'm doing is I took from several presentations just to kind of give us a wake-up call during this half hour. So I'm bringing several different ideas in here, but policies and plans, know them, know there may be inaccuracies in them. And some of you may know Dr. Chris Held. This was an example that she had. There was a plan that listed her as a provider in their network, and she was in fact not a provider in their network. That was very intentional, something that they did. So if you are on a regular insurance plan, confirm with the network that the doctor's in their plan, but I'm also going to say confirm with the doctor that the doctor is in their plan, and ask the follow-up questions, being, is the contract with that physician, or ask the physician, are you planning on continuing with that plan during this next year? Sometimes it's legitimate. The updates just haven't been included yet. You know, sometimes we look online, it just hasn't been included yet, or there might have been typographical errors. The important thing is we have to be the ones to search and find out. I would also, on that bullet, print off or take a picture that shows the date, because you can use that as leverage in fighting things. The person that sold you the plan, I know many people have gotten upset with their insurance agents. Sometimes they don't know any different. They are selling you what they know. In and out of network, I mentioned that a little bit earlier, that all the people may not be involved with a network. There was a study done in Texas a couple of years ago, and there was not a single ER physician in network in any, for one insurance company, in any hospital in the whole state of Texas. So I'm interested to see what's going to fall out in Congress on that right now. Insurance companies are changing the rules. I've already mentioned going to the ER, the diagnosis being determined not to be. Another example, there was a woman that went, she thought she was having an appendicitis attack. It was ovarian cyst, and they would not pay for that ER room and the charges associated with it. I've mentioned calling the number on the insurance plan before you go, if it is at all possible. Know things like with Medicaid, they can financially take a person's home and other assets. I know I'm dealing with that right now with my mother. Financially, she is not in great shape, and if she has to go to an assisted living, which we may be at that point, I'm finding out about all of these things in Tennessee, and what can happen and what can be taken of hers. Medicare observation status, I've already talked about that. One other example I want to bring up here, a couple of years ago, my mother was she was going to have some knee surgery. And we had been going to the doctor and talking with him for 2 months prior to. 100% of those conversations were that as soon as she finished her surgery, that she would go to an inpatient rehab facility. The afternoon before she was to be admitted to the hospital, the physician called me. He's a very reputable physician. We'd had really good encounters with him, but he called me and I just happened to ask the question. Now, I just want to confirm after she is released that she will be going to inpatient rehab. And I was stunned at what his answer was. And he said, no. And I said, we have talked about that for 2 months. And I said, you are saying no. I said, I have some questions for you. Do you know if she lives alone? We were going up on a holiday season, and I said, if she is ill and she is in a rehab facility, then someone else later on, if she's feeling better, could do that. We're in a holiday. We're in the period of a holiday, so I don't feel comfortable that the best physical therapist might be available to come and do her rehab. So I had a lot of questions, and we postponed that surgery and went with another physician. And everything was decided, and then the question changed the afternoon before she went into surgery. The ambulance bullet that I have is my example earlier that I mentioned about my friend named Matt. 8 out of 10 bills do contain errors. As I mentioned, some are honest mistakes. I will also say that I think some are fraud. 85,000 codes. I look at Charles from the libertarian perspective. We have gotten to a point where it's just ridiculous. A couple of the codes, or 3 of the codes I've given you on how ridiculous it has become are: one is I was bitten by a cow, pecked by a chicken, a pedestrian on foot is injured in a collision with a roller skater. And that's how ridiculous our coding system has also become. It also, though, makes me feel for the physicians out there, what they're having to deal with administratively in coding just to provide medical care for us. Always, when you get your bills, check for duplicate charges to make sure you weren't billed twice for a single service or a procedure. That happens pretty frequently. Canceled tests or procedures. I'll give another example with one of my brothers. My brother was not going to make it. I spoke with a physician and I said, if this were your brother, would you do any other test? And he said, I would not. And I said, then I'm going to request that we not do anything further. I had been told that he was brain dead and it was a matter of time. So I was in the ICU with him, and a couple of hours later, a nurse came in with some things, and I asked her what she was about to do, and it was a test. And, they are so busy in the ICU. The communication had just not gotten to her to not do any more tests. But let's say that you are in a situation and that communication had not happened, you're going to get a test and you're going to be billed for a test that you should not have gotten. So always be aware. ICU nurse example. I was speaking with an ICU nurse and he gave me an example of something that just again raised my frustration level with what's going on medically. We know that hospitals are not overstaffed right now with good medical personnel. They are really running around with nurses and physicians, etc. But he said a patient had been in surgery, and because they were understaffed, they did not have time for the patient to take the time to come out of recovery. And so they said they made a quick decision. Someone made a quick decision to take that patient to ICU. And he said, Patsy, that patient should never have been taken to ICU. So the family or the insurance company or someone then was on the hook for an ICU charge that really should not have happened. Correct patient information, wrong name spellings, wrong policy numbers, misprints, insurance IDs could be wrong. So all of that can make a huge difference for you financially, just to make sure all that's correct. Upcoding charges. There are different levels of charges for a procedure, and sometimes it is upcoded to a more serious set of circumstances. So being aware of that. Unbundling charges for things. That's kind of the hospital room example that I mentioned a little bit earlier. Incorrect quantities is another thing that I see quite frequently on the quantities not being billed correctly. Operating room and anesthesia time. If you underwent surgery, patients are usually billed in 15-minute increments. Mistakes can add up pretty fast there. Other gotchas. There was an article, actually it was in 2016, but it got some press again about 2 months ago, where a father was charged $39.35 for holding his baby. Catheters. I'm going to use my mother as another example. We were at the ER about 4 years ago, and she had broken her hip. And I asked, she had to go to the bathroom. She was hurting tremendously to even move, and they were going to catheterize her. So after she went to the bathroom, they were understaffed, and there was not a room ready for her. They weren't sure when they were going to do surgery. They were going to remove the catheter. And I said, why are you removing the catheter? Because it sounds like she's going to be here for several hours. She will have to go to the bathroom. And there's first of all, there's a cost for every time they do it. And I, personally, I'm not a medical professional, but I thought there's also opportunity to introduce bacteria or whatever. And they said, well, that's our protocol. And I said, if I need to sign something, I will. But I didn't want to see that charge, and I did not want to see her go through that turmoil every time she had to go to the bathroom, and they were understaffed and they had to come back in again and do another catheter. Always check for procedures that are ordered and not done, and be very aware of your check-in and your check-out times in the hospital, because that can make a big difference too. I had another situation with another family member, and they were understaffed, and so my family member didn't get out of the hospital when they should, and I did not want another day payment or part of a day payment when it was their issue, but that had been documented, and we were able to fight that and get it changed. Again, I'm going to bring out having medical notebook, document, discussions, phone conversations, times, dates, who you spoke with. I also, when I have a family member in the hospital now, I take pictures with my phone. I take pictures of the IV bag. I have a voice recorder. I will make notes on who came in, what was discussed, etc. Get the detailed bills. I've already mentioned that. We would not go to the grocery store and have them give us a summary bill that said our bill was $290 without looking at the detail of what was in that bill. And we need to be, I hate to say we're at the point where we have to be that diligent on our medical bills. I'm sure everybody on this call knows that an EOB is not a bill, but do get the detailed bill. Many times you will be upcharged too if you are seeing physicians associated with hospitals versus those not associated with hospitals. And because of some new laws that have gone into place, I'm going to go back. I don't blame this on physicians at all, but their hands are tied, and annual visits are much more stringent. And if you go outside what was supposed to have been in that normal annual visit, there could be additional charges for things. Second bullet on this one is it is important to negotiate. And I think if we have the documentation, we can negotiate. But you don't want to negotiate 50% off of something that you didn't know in the first place. I've got that bullet in there. I pulled this from several presentations, so I've got that bullet in there about the ER cost. Let's talk about electronic health records and what's going on there. Almost weekly in the news now, we are seeing hacks taking place. It's taking place more and more in hospital settings and with medical records. If you think about all the information that is associated with your medical records, it is much more valuable than if Target was breached or something, because you have so much more information there. I'm going to tie that thought process in with electronic health records. I think the reasoning for why electronic health records started was good, but we have done nothing that goes back to that original reason. The original reason in general was if you have an electronic health record, and let's say that you go to a hospital, I'm in Tennessee, let's say you go, but I travel a lot, let's say I go to a hospital in Tennessee and there is an electronic record for me, and then I'm on a plane and I go to California. Originally, the thought process was if I go to that hospital in California, they could pull up my records and have everything. That's not the way it's worked because there are so many systems, etc. So the original intent, we have not gotten there at all. Secondly, I'm very concerned now on our records being compromised. There is a statistic that 1 in 4 consumers have now had their health records compromised. Get copies of your records for a number of reasons. One, you want to look at what is correct and what is not correct in that record. And we've all done this just in regular typing. We will copy and paste. That is being done to our records. So sometimes copying and pasting is done from somewhere else, and there's something going in our record that is taken from another person's record just for ease, and it's not accurate. Therefore, it affects us medically and it affects us financially. Let's say that there was a copy and paste, and I had a client call me. He said, I'm not a diabetic, and my record is showing I'm a diabetic. But if he had not gone into his record, he would never have known that. And then it takes a lot of time to get it corrected after that. But the other reason we want to have our records, and just this week, there was another article where a hospital had been compromised and it brought their system down. They could not get access to any patient's records. So if you have your own record, if a place is compromised, at least you have a copy of what that record is. Medical record theft is it's a huge target on the black market right now. You can cancel credit cards, but your electronic health record is out there. It compromises you financially, but it also can compromise your health. I had another client, his daughter, someone had gotten her records. They had used her information and went in as a patient as her. And let's say, I'll use a wild example. Let's say it's a once in a lifetime procedure. Someone else compromised your medical record, and they acted like it was identity theft in essence. They acted like they were you. And let's say it was a once in a lifetime procedure, a right leg amputation. And then later on you needed that to be done. You could not have it done because it had already been done. Plus, many times what we're finding now is people are actually having to pay for things that other people are having done under their name. So this is such an important area that I don't think people have awakened to yet, that I think we're going to see some, people are going to start realizing the impact that it's having on them individually.
Patsy?
Yes.
So we're running into the final 10 minutes or so, and so I thought we could maybe start taking some questions if you want, or
okay.
You want to make a last couple of points before we take Q&A.
Sounds great. I tell you what I'm going to do is I'm going to just flip through the slides, not talk about them, but let you know what's there. So if you want to go to them, how about that? And then
Perfect.
we will, I've got some examples of if you want, Charles, DPC is great, but to search for things like GoodRx, Prater, just search cost of care, etc. I've got some examples from Clark Howard on searching for drugs, how to get free prescriptions at times, using apps to comparison shop, shopping at Costco, getting $4 prescriptions is mentioned in here. So those are some of the other slides that are out there.
That's great. I wish we had more time to go over each of those because this is a wealth of information. And what a complicated minefield hospitalizations are. And to that end, if folks could unmute themselves and click the raise hand icon to ask their questions. Personally, I would love to hear from CJ Wilson, how his records vault kind of deals with some of the electronic records traps, and also Dr. Taylor, maybe speak about standalone price disclosed surgery as a way to escape some of those hospital traps. And so many of you on this call can offer suggestions. I definitely will plug cash paying to get away from some of the network problems and coding. And man, that's great, Patsy. CJ, I see your hand is raised. Go ahead.
Thank you. Can you hear me okay?
Yep.
Patsy, thank you so much for today. That was very, very informative. And I did have a quick question. Of the three principal areas of work that you are doing, you mentioned there at the last that you're helping people with their bills. And how do you price for that service, or do you charge for it?
I do charge for it. I do it a couple of different ways. Sometimes I will do a fee for me to basically give them direction on what they need to do. Sometimes if I actually go through all the steps myself, I will charge a percentage of savings.
Well, that is wonderful. We have seen other people doing it, and it's so needed. What Jeff mentioned there, we really help to pull the medical records together. You mentioned the high number of errors in records, and that's absolutely right. But that's on the record side, and then it comes to the billing side. So as much as we pull those records for people, as much as we allow people to and their family to track their health, which is really our strength, those two areas, boy, we would love to take those same records and assist you or have people work with you as we assist them on those back to the billing side of it. So thank you.
Thank you.
Yeah, sorry about that. Yeah, CJ handles our vaults where members can get all the records worldwide, lifelong, and all that are consolidated on their key fob. Wow. So the primary care doctor has a look at them, but they need to be cleaned up. Dr. Taylor, I see you unmuted. You want to comment on some of what your experience as a surgeon and what?
Yeah, hi.
Go ahead.
Can you hear me okay? Okay.
Yep.
Yeah, as a surgeon, it's amazing to me. I get to see both sides. I'm a solo practitioner in plastic and reconstructive surgery. So half of my practice is really like a retail medicine practice with cosmetic surgery, skincare, and med spa services, which works very well. You know, we have non-transparent pricing. People come in, they find out what it costs, and they pay, and everything goes very smoothly. Then there's the other side of my practice, which is the reconstructive surgery part that deals with insurance billing and whatnot. And it's just amazing how much more complex and difficult that part of the practice it is. And Patsy's just, you're so right with the complexity when it comes to in-network, out-of-network, different services in the hospital. It's just the lack of transparency is really mind-boggling, even for those of us who are in the system, entrenched in the system. And to me, things just really are going to have to change. I mean, really be completely dismantled and put back together again. And I don't see any other way to really fix this mess that we're in. And it's a huge mess.
It is.
So if we can all just run our practices, like we do as plastic surgeons with just non-transparent, transparent retail pricing, it could really work well, and it works smoothly.
Here, here. Paul, documentarian, Mr. Roberts, go ahead. Paul, get yourself muted. See your hand up, so when you unmute yourself or figure out how to speak, go ahead. But it looks like you've got yourself muted, Paul. Bob Stobble, are you there? Do you want to comment? You're sort of a man who knows everything about healthcare. So you got yourself muted. So Patsy, what are some of the legislative projects that you might take on as a result of your in the weeds discovery of all of these errors and fraud and complexities. I mean, you kind of snickered at the Trump hospital price disclosure rule, how hospitals are going to game that one as they do most regulations. Where you had it legislatively?
A couple of things. One is I am an advocate and will speak loudly to members of the legislature and Congress on things that need to be done. As many of you know, there is a lot of money spent behind the scenes from lobbying efforts that make an impact. And I think as each of us on the call have a passion about what we're doing. And I think it is up to us to try to change what's going on. I do think there are, just like I think there are wonderful physicians out there, I do think there are some wonderful legislators and some wonderful members of Congress, and it takes them being educated. Legislators don't know all, even people in the medical system, until they are a patient, don't realize what's going on. So, part of my goal is to allow the legislators to know what's going on, so when they're making rules, they are not blind to what's going on. The balance billing has been a huge one, and I'm interested to see, even on a state on a state basis, before all this started being discussed, there was so much misunderstanding and not a comprehension. So education to them in the major transparency, to me, is the top. I may be wrong, but that's the one that screams to me. We don't, it's the only thing I know of in America where we cannot get a price for what's being done. And it's after the fact. And many times what we get after the fact is wrong.
So true. And, our back office concierge negotiating behind the scenes with the hospital is huge, because it is hard for patients to negotiate. And you gave some good examples here, how to start that negotiation process a bit, but holding the patient's hand is really important. And you're doing a great job, and we try to do the same thing. Abigail, if you want to unmute yourself, I'd love to hear your thoughts as a state advocate in Michigan, if some of these issues have crossed your plate. And while you unmute yourself, Bob, I see your hand up. If you want to unmute yourself and ask a question, Bob? I think you have yourself muted. Because I don't have you muted. So we're running towards the end here. If anyone wants to unmute themselves and just blurt out a question, it is up to you to go ahead and do that. Otherwise,
can you hear me now?
Is that Bob?
Yeah.
Go ahead, Bob.
Oh, yeah, sorry, I was having problems with my mute function. Well, first of all, thank you, Patsy. That was great. I learned a lot. I just wanted to throw out one of the issues here for anybody on a health plan that has a maximum out-of-pocket, out-of-pocket maximum. So when you go into a lot of, when you're initially going into a hospital or a procedure, you're highly motivated to do everything you're talking about as an employee on a health plan. You're motivated to, save yourselves copays, deductibles. Once you're over if it's say $10,000 maximum out of pocket, there is no incentive. So, why push back to your doctor? Why, go out of your comfort zone, to be so pushy, because you have to teach people to be kind of pushy, to get these results. So I just wanted to throw that out there as a real issue. The way large employers are dealing with it is they offer centers of excellence for surgeries optional to the employees, but they waive the copay and deductible, and they say, if you have your need done at our center of excellence, again, you don't have to, but not only will there be no copays or deductibles, when you get home, we'll pay you $1,000 in your next paycheck. So that's the incentive, because a lot of those employees are going to be over that maximum out of pocket. So the way employers can deal with it is to incentivize use of a narrow network of bundled payment centers of excellence, and to write a check back to the employee But I'm not sure how to deal with it other than that one way of dealing with being over the mat.
And I don't have anything else to offer, but I love what you said the employers are doing.
Not many, but it's something, you know, that hopefully will catch on.
Yeah, LinkedIn, Bob's part of these Rosetta brokers for big companies, and
Okay.
boy, are they innovative with their direct contracting and struggling to cut costs. And they're beating their heads against the wall in some cases with employers that don't want to deal with it, or HR companies that have a relationship with a carrier broker. So kind of like what we're doing with individuals and small groups, it's tough to get the patients to step up and accept the opportunity to pay cash and shop around when they're used to having someone else take care of it. And Patsy, what you're saying here today is, look at what we've done to ourselves, this cavalcade, this avalanche of mistakes, fraud, and complexity. And this is a disaster. So Patsy, why don't you tell folks how to reach you, and then we'll close.
Okay. My website is managehealthcarecost.com. That's COSTS. And I'll give you my phone number. It's 615-310-7003. My email is patsy@managehealthcarecost.com. And I would love, I appreciate everybody on the phone, because I know this is a passion to change what's going on in our country with this. Any examples or any way that I could assist you, or examples that I could use in presentations to educate others, I would welcome.
Outstanding.